A very big hello to all my dear students. Today I'm starting a new journey with you all. So, this channel, YouTube channel, which will be called You and I, with, of course, my name, Dr. Ruchi Rai, we are going to start a series of what we call T2O. What is that? It would be Tuesday, Thursday, Ophthalmology. So every Tuesday and Thursday, I'm going to try my best that I'm there talking about some topic, maybe image based question, maybe some PYQs, maybe some clinical scenarios, right? And please take this opportunity to ask as many doubts as you want. You can just DM your doubts to me, message me. I'm going to address all your doubts there. And let's be in touch and keep revising all important topics as well. And maybe someday we just talk and I'm just sitting inspiring you all, right? Okay. And since my English version has also been appreciated a lot, so I am going to post my English version on Thursdays and English version on Tuesdays. So hope we both enjoy this new journey together. So all the best to me and all the best to you. Okay, so let's start with the first session. And please note down the Insta and Telegram because it will be very convenient for you to coordinate with me. We start with a clinical scenario here and this discussion. Okay, before I go further, see any question we can discuss in as much detail as possible, which can last up to even an hour. But the whole purpose of this session would be not to tire you all, but a very, very quick discussion on important points and the important questions. So it will be a very quick discussion. So if you feel you want me to speak more about any topic, you will message me and I'll do that. Right? Okay, let's start. We start with a 35-year. So we'll start with a clinical scenario. Let's take one clinical scenario. 35-year-old sickle cell patient comes in after being hit in the eye with a soccer ball as shown in the image. Right? So, what are the important points? Whenever we are solving a clinical scenario, we should always note down the catch points, right? So, there is a blunt trauma in a patient with sickle cell disease, and he has severe pain with vision decreased to 6 by 60, and intraocular pressure is so high. We all know, obviously, the clinical pictures in front of you. We are talking about hyphema, which has been induced by this blood. And because he's a case of sickle cell, we know he's more prone for all this. What are the two major? Okay, let's first read further. Which one of the following is the most appropriate treatment? So, what should you do immediately for hyphema? Should I aim for lowering the intraocular pressure? Okay, it should be timolol, or dilating the pupil with eosinophil, entropicamide, anterior chamber washout, or cryopexy to reduce the ischemic areas. I think the options are so simple that obviously the answer has to be anterior chamber washout. What we will keep two things in mind regarding hyphema, that whenever there is hyphema, there are two main problems in this patient that can happen. One is more pressure, as you can see in this case, the pressures were very high. And secondly, very, very dangerous is corneal staining, because then you can't do much about it. You have to replace the cornea. Okay. So therefore, the immediate treatment always will be wash out and remove the blood from the anterior chamber. Okay. Let's talk about a few PYQs now. Most common site of blowout fracture. Many of you make this mistake again, and when I say PYQs, I'm including all the exams here. It can be NEET PG, FMG, INI, CT, all three. Okay, so it will be mentioned below the question. So, most common site of blowout fracture. So, most common site of blowout fracture. First of all, please understand the word blowout fracture is referring to fracture floor of orbit. Okay, and when you talk about fracture floor of orbit is blowout fracture, the term is for this floor fracture only. Secondly, the most weakest part of the floor, it is posterior-medial part. Please remember this. This has been an important exam question. Another question related to this that needs a mention here is, which is the weakest wall of the orbit? Please don't confuse with these two questions. Weakest we will always answer is medial wall. Why medial wall is the weakest wall? All of you, because of lamina papracia. I think you need to also know the bones that form the orbit. You should be clear about that as well. And in a blowout fracture, what do you get? When there is a flow fracture, we will not forget this. It's a repeated question. This opacity in the maxillary sinus here that you see. What do you call this? Teardrop sign. Okay. So these are some important points we will not forget. Correct? Okay. So don't forget this teardrop sign, which is a feature of blowout fracture. We come to the next question. Fasanella Servate operation. You remember we are talking about mild ptosis. It is done for ptosis. And which ptosis? We are saying mild ptosis. What is mild ptosis? When it is less than or up to 2 millimeters. Okay, because Muller resection. What is Fasanella Servate? First of all, we are everting the lid. Look at it. We are everting the lid, cutting a strip of conjunctiva, tarsal plate, and Muller's muscle. Okay? And then restitching it. After the cut, we restitch it. So Muller's muscle can only correct up to 2 millimeters of ptosis. Okay? Up to 2 millimeter drooping is what is mild ptosis. Okay? So Fasanella Servate operation is done for mild ptosis, particularly done for, let's always remember, Horner's syndrome. Why? We all know that in Horner's syndrome, it is mainly the Muller's which is gone, isn't it? Because Muller is supplied by sympathetic supply. Horner's is lesion of the sympathetic chain. Okay? Therefore, we should know that ptosis in the Horner's syndrome is due to Muller's muscle. Muller's muscle को और क्या बुलाते हो? We call it superior tarsal muscle. We come to the next question. Drugs used for treating retinoblastoma. We all know VEC. Okay? So answer is vincristine, etoposide, and carboplatin. So you should remember it is VEC. Carboplatin is the most important you have to know. Anyway, all the three are given in the regime. So please revise the classification of the retinoblastoma, that is your ISCB classification. Okay? So international classification ICRB classification भी बुलाते हैं इसको, that is international classification of retinoblastoma, or we are calling it IIRC. ठीक है? अब इसमें क्या है? If you have very quick revision, we divide it. This is stage 1. Stage 1 is what? We are dividing into A, B, C, D, E. There are 5 groups. So I want you all to have a very quick revision here that when you say A, it is less than 3 millimeters in size and it is away from the important structures, that is macula and disc. If it is group B, it is more than 3 millimeter in size and it is near the macula and disc. This is way. So learn with me A and B together, C and D together. Okay? Then coming to C. This is more localized, but it is, now we are talking about the distance and seeding. Okay? So what we are saying is that the tumor is, there is spread, but it is within 3 millimeters. The tumor cells which are spread, where it is spread, vitreous में or subretinal fluid. Just remember these two. So in the vitreous and subretinal fluid, when it is within 3 millimeters of the, so इस बार हम distance की बात, we are talking about distance, not the size here. So when it is within 3 millimeter from the tumor, or it is more than 3 millimeter from the tumor. So within 3 millimeter distance, again it is the vitreous seeding. Then we will say this is your group C. And when it is more than 3 millimeter distance from the tumor, this seeding is group D, more diffuse. Okay, and where is the seeding? What did I say? It is in the vitreous and subretinal fluid. We are talking about vitreous and subretinal fluid. Right? And what is E? Now it's a very big tumor occupying more than half of the globe, that is E. So this classification is important and therefore I gave you my method how you will remember the classification. So if it is E, definitely we know we have to go for enucleation, right? So because this question is on treatment, we should very quickly revise the treatment of retinoblastoma here. So if you talk about treatment, if I talk about 1A, this is group 1, this is stage 1. 1A, we can go for localized therapy. with cryo and laser. When you talk about B, C, and D, we have to start with chemo, reduce the size of the tumor, and then go for either cryo or laser. When we are going for E, I told you we have to remove the I, that is enucleation. Once you have removed the eye, you are doing what is enucleation? You all remember? Removal of the eyeball with maximum part of optic nerve. Once you have done that, you will do biopsy and see whether the optic nerve is involved or not. If it is involved, this becomes stage 2. And if the optic nerve involvement is there, then what you have to do along with this enucleation, right? You have to go for chemotherapy and radiotherapy. That is stage 2. Okay. So stage 2 is I'm not writing everything. It's a quick discussion. Enucleation with chemotherapy and radiotherapy. What is stage 3 when it is going into the orbit? That is extraocular extension. Anything which is going into the orbit, what will you do? Exenteration, right? So what is exenteration? Another way of removing the eye where we're removing all the orbital contents so that the tumor doesn't spread to the brain. And lastly comes group stage 4. What is stage 4? It is distant metastasis. Of course, the treatment would be palliative. So I think retinoblastoma is very, very important topic. So I just discussed it a little longer, right? So we will keep all this in mind. So what is the next? Next question. Okay, I had kept a page for this, but I haven't discussed everything on this page. I hope it's comfortable. See, this is what I've written, right? Yeah, here it is. It's better? Okay. Then we talk about next question. Next question क्या कहता है? Which layer is responsible for maintaining the cornea in a dehydrated state? We all know we are talking about endothelium. Another PYQ for you all. So we will not forget, again in my simple way, let's make ophthalmology very simple. If this is the epithelium, the stroma, this is your Bowman's membrane, this is your Descemet's membrane, right? ये हो गया Dua's layer, the dotted line, and this becomes your endothelium, right? Correct? So, main purpose of endothelium is to keep the cornea in a dehydrated. So, all of you can think with me like this, that if this is the cornea, this is the aqueous humor, see it is all around surrounded by water. How come it's in a dehydrated state? So, what is endothelium doing? Endothelium is not only acting as a barrier, usko kya bolte hain? We call it barrier function, but it is also the pump function. What is the pump function? We have sodium potassium ATPase pump, which is continuously pumping the water back into the aqueous. Okay, so answer is pump function and barrier function of endothelium cells help to maintain the cornea in a dehydrated state. All of you, please revise what are the factors responsible for maintaining the transparency of cornea. Take care. Next, shifting fluid, that is CNS. A lot of fluid in the subretinal space. How do we know it's shifting? Because with this shifting of the posture of the head, when the fluid shifts, what happens? The retinal detachment position shifts. See, this is so interesting. This is ultrasound B scan. And what can you see here? In one position, this was the detached retina, correct? And in the other, now this is the detached retina. So the detached retina position, it's changed. Why? Because of that shifting fluid, we are getting these two pictures. The feature of exudative retinal detachment. We will not forget this. Okay. So we are talking, what is exudative? I hope you all know. Exudative क्या होता है? When the pathology is in the choroid and that percolates into the subretinal space. You remember this diagram, all of you? ये choroid है, right? Then we know that a membrane between the choroid and retina, this one is called your Brooks membrane. This is the innermost layer of choroid, right? This is your retinal pigment epithelium. And if I talk about, these are the different layers of the retina, right? Let me not make it with red. We come back. Mando, these are the different layers of retina. So what do you see here? This is called neurosensory retina. We all are clear now what is retinal detachment, separation of retinal pigment epithelium from neurosensory retina. ये वाली जो space है, this is called subretinal space. ठीक है ना? So any fluid, any pathology of the choroid, neovascularization, tumor, where it percolates into this space and causes separation here, that is what is called exudative artery. ठीक है? I hope you will remember this, that shifting fluid is a feature of exudative artery. Next, we talk about what is this? A woman came with a complaint of progressive loss of vision of the right. So please, all of you, revise your lesions of visual pathway. I can take the topic separately. I will not be able to discuss in detail here, but think yourself. Where is the lesion when there is a loss on the right side? What do you mean by right side of the eye? Right eye, right side of both eyes. When you say right side of both eyes, let's make this. This is the left eye, right eye field. I'm saying right side of both eyes. This shaded part, this is your field effect. Right? See? We'll take this quickly. So shaded part is the field effect. So what is this? Right homonymous hemianopia, isn't it? So this will be seen in what? Left optic tract lesion, isn't it? So always one side, it always causes opposite side field effect. One side lesion causes opposite. So answer should be left optic tract. So again, revise your lesions of the visual pathway. So very quickly with you all, if whole of the nerve is gone, what is happening? एक तरफ का पूरा चला गया, it is going to lead to, so it is the right side, this is right eye, this is the left. Left to left, right to right. This is how we learn the visual pathway. First of all, be clear about this. So if it is from this side, this there is ipsilateral blindness. Okay? Okay. And when number 2 lesion, what is number 2 lesion? Both nasal fibers decussation. So please, many of you get confused with this. You have to understand that the retinal coordinates and the field coordinates are opposite. मतलब क्या है? If the superior retina is gone, it is the inferior field effect. Inferior retina, superior field. Similarly, if nasal fibers are gone, temporal field effect. Temporal is gone, nasal field effect. As each other. Okay? So here both nasal are gone, so we are getting bitemporal hemianopia. If bitemporally, then it is binasal hemianopia hai. Then it is showing, then if it is, this is the right-sided lesion, we are taking an example. So we are getting a left-sided homonymous hemianopia. Simple. Again, we talk about, when we talk about optic radiations. Now it will depend. Are we talking about the fibers which are coming from temporal lobe or from the parietal? So fibers passing through temporal lobe are inferior. We get a superior field effect, a superior quadrantopia. This is temporal lobe lesion. Okay. And if it is visual and vice versa, what is inferior quadrantopia? Parietal lobe lesion. It's not made here, but you should know this. In the posterior part of the parietal lobe, whole of the optic radiation is gone. Then you can also get homonymous hemianopia of opposite side. But in this question, if both radiation and tract is given, we are going to first talk about tract. Correct? And of course, what is the last thing it shows is the cortex lesion, where posterior cerebral artery occlusion is leading to macula sparing homonymous hemianopia. See? Okay, we can take this again as a separate topic if you will ask me. We come to the next question. All of the following are correct about third nerve palsy. We all know what is third nerve supplying. All the muscles except superior oblique and lateral. है ना? Okay. सबको याद है ना? LR6, SO4. So these two muscles are not affected. What does LR do? Abduction. What does superior oblique do? So you should be very thorough with the action of the muscles. Superior oblique भी abduct करती है. It is going to, what else? Primary action, intorsion. Superiors are intorters. Right? And of course, it causes depression. Okay? So you have to remember this. So which is asking you, all of the following are correct about this except, of course, lateral and upward gaze palsy. No, laterally it can go. The eye actually is down and out. What is the position of eye? It is down and out in a third nerve palsy. Just remember this. Right? Okay. See, this is the case of third nerve palsy because third nerve supplies the LPS muscle. So I can see on her left third nerve palsy here, left-sided third nerve palsy, where you can see the left-sided ptosis. You know, because of LPS involvement, we are seeing ptosis. On the right gaze, no adduction here. Okay, but on the left gaze, abduction is possible. Correct? Okay. This is third nerve palsy. Of course, this question has been asked so many times. Stve strategy includes. So, do we all know what a Stve strategy includes? Just surgery, antibiotic, facial hygiene, environmental cleanliness. Everybody is clear about this? Okay, so what will be the answer here? All of them. So this surgery, with surgery, you should know here, this is we are talking about trichiasis surgery, or you can say entropion, right? Antibiotics preferably is oral azithromycin. We can also go for topical tetracycline, right? Okay. We come to the next question. So remember the Stve Strategy, which is a WHO program to control trachoma in any community. These are the points you should. Achha, one more question on SAFE for you all. What is the criteria? When should I start SAFE in any community? You will answer when the prevalence of trachoma follicles is more than 10%. In any area, when the prevalence of trachoma follicles is more than 10%. Correct? Okay. Next, which test is used for stereopsis? We have to know about Titmus Fly Test. Okay. So, stereopsis is your third grade of binocular single vision. If I ask you what are the grades, grade 1 is simultaneous perception. Hai So, grade 1 is simultaneous perception. Grade 2 is your fusion, and 3 is your stereopsis. Okay, so we will answer Titmus Fly Test. Okay, so here it is. This is the Titmus Fly Test. क्या करते हैं उसमें? What we do is we just ask the patient to wear those Polaroid glasses, and after that, look if he can see that okay, if he feels that okay, the fly is flying actually above the surface, then it's the depth perception and stereopsis is fine. But if he cannot, then it is not fine. This is how we test a stereopsis. ठीक है, चलेगा? Okay. We come to next. Evisceration is removal of which layer of, please remember, what is evisceration, all of you? We are cutting the cornea, scooping everything, leaving behind the sclera. Isn't it? So, all the inner layers of the eyeball are removed except the sclera. So, what will you say? Evisceration is removal of which layer of the eyeball? You have to say middle and inner layer. Isn't it? The outer sclera is left. Right? Yeah. And what do we do? Either we stitch it, or if it is infected, we have to wait for it to heal, and then we put scleral shell over it, which looks like again an artificial eye. Right. And so you have to keep in mind what is evisceration. I just talked about enucleation, where the whole eyeball is removed along with maximum part of optic nerve. You know? That was enucleation. You'll never forget enucleation if you remember this diagram. So it is maximum part of optic nerve is cut. Right? Okay, see, this is a patient before and after. That means there was some thymus bulbi, the evisceration is done, and the scleral shell is put here. Okay. Right. Next we talk about is retinitis pigmentosa. Which of the following is seen in retinitis pigmentosa? So everybody should remember the triad of retinitis pigmentosa. क्या होता है? That is your pale waxy disc, right? Pale waxy disc is consecutive optic atrophy, then attenuated arteries and bony spicules. Okay, what are bony spicules? We all know these are pigmentary disturbance. So here it will be arteriolar attenuation, right? So see here, these are the bony spicules. So there are a lot of questions on this. Please revise your retinitis pigmentosa very thoroughly. And these are the arterial attenuation, right? And pale waxy disc. This is the consecutive optic atrophy, pale waxy disc. Right. Okay, is it clear to all of you? Yeah. Okay, we come to this one. Not used for color vision testing is. So color vision testing, you all should be very familiar with all these three terms. What is Holmgren wool test is also different types of colors. So let us have a look. What is Holmgren? So this is the different color of the wool which is asked, patient is asked about, right? What is this? Farnsworth Munsell 100 hue test. which is asked very frequently in your exam. And what is the third one? This is your Ishihara chart. Ishihara chart, sorry. Ishihara chart is mainly for screening of the color blindness, isn't it? So what will be the answer? All our tests except we will answer AMIS test is not a color vision testing. Right? So that was a quick and short discussion, and hope we will be continuing to do that. And you all are going to respond well, ask more questions and ask more doubts, right? So happy learning, stay blessed and keep smiling. Thank you so much.